please don't fall asleep. I know that it's possible from that aspect. Uh, from the aspect, when Andrew kind of sort of spoke to the aspect of review for medication-assisted intubation, a term of rapid sequence intubation, because if you really go and think about it, it's not always that rapid. A lot of times it takes anywhere from 45 to 60 seconds. After you push the etomidate, push the Versed, and then you push the sucks. The sucks doesn't always work, so you have to give additional sucks, and then that doesn't work, and then you're like going, oh, okay, well, so more along the lines of using the term medication-assisted intubations, which I think is just a cleaner term and all that stuff. You guys should know, at least the medics for now, the protocols or the guidelines for the medication-assisted. If you don't know that, then we have some huge, serious concerns and all that stuff, and it's hard, since from that, the joke and all that stuff. So, okay. So, I mean, you guys should know the guidelines. So it's really not the aspect of trying to get away from the medications. You should know all that, the drugs, dosages, all this. So trying some different tricks of the trade, reminders, and this is both good for the EMTs along with the advanced EMTs and the medics. So from that aspect of what can we do differently when we, the failure to intubate or failure to put that piece of plastic down the throat. So difficult airways. Maybe not. All right. So airway management is really easy, except we get somebody that is morbidly obese, big neck, that sort of thing. And some of the picture slides later, what happens if their face is blown off? What do you do then? So there's really different tricks or the things to take into consideration. If this is this is anesthesia and all that stuff. So if they really look at it, their difficult airway, do they recognize it? Don't recognize it? If it's unrecognized, they go through their general anesthesia, paralysis, do all that stuff. They fail it, what do? They stop, wake the patient up. Okay? So the same thing, or they might try a mask ventilation. If that doesn't work, they might try one of the combi tubes, surgical airways, or something like that. If that doesn't work, they stop, they wake the patient up. Okay? Or even down to here, the mask ventilation doesn't work. If it's a non-emergent pathway, they can try intubating, or if it fails, again, what do? They stop. Okay, they cancel the case. They don't care. So their options, anesthesia options, is really different. So they plan in advance. Okay, they know what they want to do, how they're going to do it. They know that it's going to be a difficult airway, which we'll go through in a little bit. They're going to have all their tools of the trade. They might have the video scope. They might have the actual fiber optics. They might do what's called a wake intubation, where they just get the patient paralyzed, paralyze the vocal cords, all that stuff, do a nasal intubation. So different things. So they get an airway, they wake the patient up, they regroup, and then they go for coffee. Okay? For us, on the other hand, what were we going to do? Okay, if we can't get the airway, we wipe our brow. Okay, we change the shorts. We call the attorney. Okay, because we can't get the airway, they die, or we call the coroner. All right. Sometimes if it's bad enough and you can't get the airway, this is where we're getting to. So it's going to be difficult to oxygenate. It can be ventilate problems. Okay, if it's just the aspect of getting the plastic down there, or if you need to perform the crike. In crike, how many have actually done a surgical crike? Only in lab. Okay. Not really that different from the human and all that stuff, your landmarks. All right, and later when we talk a little bit with the crikes, some tricks to play with and all that stuff. All right, maximize success, recognize, predict, Choose appropriate techniques and equipment. Okay. If you know they a big neck, they're in a cervical collar. Okay. What do you want to have with you immediately? What's the potential things? Backup airways, such as what? Okay. LMA. What else? Suction. Right. It's a bloody mess. You gotta make sure you got good suction that's working. That little hand pump isn't always gonna happen. Right. You're bougie. I'm a huge, huge believer in having a bougie. Has technique, skills, drugs, and devices. Would you guys have this? I have confidence in you. Okay, that's why you guys are the only department that has the ability to push paralytics. That's how confident I am with you guys. Predicting. Okay, if you have time, we talked about this before, the lemon law. All right. So look, evaluate malempati, obstructions, and neck mobility. So on the look side of it, are they obese? Do they have facial hair? Okay. Can you actually be able to set or sit the BVM? If you can do that and ventilate through a BVM, most of the problems on the look side of lemon is really a moot point. Okay. Because if you can't get the ET tube, what can you always do? Oral airway and ventilate them. Okay. You might not be able to get the tube, but who cares? If you can ventilate and oxygenate, that's all that matters. Success. I pat you on the back, give you a high five. Other thing, look at large teeth. They can potentially obstruct things. Teeth, at the summer teeth. Some are here, some are there. So we got some summer teeth here. So how would you like to have to try to intubate this gentleman here on the right? Big neck, obese. Just from the body morbidity and all that, or the body habitus, everything is going to push forward. And he has an anterior neck, small neck, big tongue. He's going to be difficult. Other aspect, do they have narrow face, high arched? Some of the small kids that you get that have some congenital malformations, the cleft palate, cleft lip, or the not much of the lip, but the palate and all that stuff, and some of the other problems. The large tongues, false teeth, try to remove all that stuff for intubation. Examine the airway. All right, your 3-3-2 rule, which is what? Yeah, okay. I thought I had it, sorry. All right, 3 in the mouth, 3 in the hyoid, and then 2 at the thyroid. So this should be put 3 in the mouth, 3 below, and then 2 to the hyoid. 3 fingers allows for intubation, allows also the aspect of, trying to get, if you have to put the king vision in there, plus the ET tube, plus, sometimes I if I know it's going to be a potential difficulty, I'll have the ET tube and the bougie in the mouth ready and then slide the scope in. So you're not fumbling trying to get the mouth or trying to get the tube in there. The mentoid, predictability to lift the tongue and the mandible and all that stuff. All right, and then the other aspect, the 2 fingers for the floor of the mouth, high airways, is the airway tucked away, base of the tongue, your anterior airways and all that stuff. Malempati, so this is the aspect of actually asking the patient if you can. Sometimes you don't get this opportunity. It's we do this a lot of times for when we go into procedural sedations. Sitting up, looking at you, have them open mouth. Can you see in the back of the mouth? What are we looking for? Uvula, okay. So what specifically how do you categorize this? I have it on the next slide, but 1 through 4, yep, okay. So a 1 is see everything. A 2, partially, you can see the half of the uvula. A 3, you can see the top of the uvula. And at 4, can't see anything at all. So 1, you see everything. A 2.5, 3 is usually just to the top of the uvula. And then a class 4, which is severe, everything's blocking. All right. So trying to get a malempati 4, and it's the aspect of can you get all your equipment in there, meaning your scopes, your blades, or anything like that? Airway instructions, all right, looks on the bubbles. Sometimes that's all that you get. Do they have angioedema? Do they have hematomas? Okay, are they wearing dentures? I have a video with adult onset epiglottitis about 3 months ago that I can show you guys later. Scary as all get up. Went in there, saw nothing, no cords. I saw a flicker of a bubble. That's all that I saw, and I was in the whisper of a prayer and all that stuff. My partner actually, when I went, because I stopped, and his words were, "Holy," you know, not like that. Neck mobility. So the last part. Do they have previous surgeries, rheumatoid arthritis, osteos, cervical, if they have anterior cervical plating and all that stuff. They can't lift their head back. So this does what to your axis? Not good. Okay? So you can't get all of your 3 axes in line to be able to see the direct visualizations. The other aspect too, okay? You have something that's potentially penetrating and stopping. Do you have a gunshot wound where you don't want to move the neck? You have the patient in the cervical collar. Right? So all those things go into the lemon law. So cervical spine rigidity, your problems with axis, inability to mobilize the neck. Of course, we know this can make it impossible, for intubations and all that stuff. All right. Questions on the lemon law? Always like to just remind and all that stuff. Okay, so moving beyond. All right. Some equipment, Olden, just again to reiterate, some of the stuff that you guys don't always have, but there are still some departments out there that are using some of these equipments. So if you happen to be potentially driving along, see an accident, and come on some of the old departments or some departments that use old equipment just to play with. Difficult, what you need to have in your bag or your armament, all right? So what bullet are you guys going to carry? What bullet are you going to use in your gun, okay? We all know about the BVMs, combi tubes, olds from that aspect. LMAs kind of sort of went away. The new intubation LMAs have been out there. They have what's called the Cobra now, I think, is the newest and latest. Actually looks like a Cobra and all that stuff. The King LT, which is the majority of what we're using with the video. Bougie's hit there, the transtracheal jet, whenever we do for kids, pediatrics and all that stuff, if you can't do to do a needle crike. Retrograde intubations, digital, had to do that the other day, even with a glide scope. Could not get the tube, the bottom of the tube, you could see on glide scope was hitting the retinoids or hitting the bottom of it. I actually had to put hand in the mouth and lift up the tube to slide it in there. First time, kind of cool. And then, of course, the crike. All right. Remember to pay taxes to the IRS. All right. So when you're looking at intubations or when looking at difficulties, all right, so the first thing is, can you actually intubate? All right. If you can't get the intubation, can you do your rescue ventilations? All right. I don't care how you ventilate the patient, as long as you do what? Ventilate and what's the other thing that you want to be able to do with ventilation? Oxygenate. All right. As long as you can ventilate and oxygenate, I don't care how you do it. So you choose from the previous slides which one, LMA, King, like what Chief said, oral airway, the BVM, and all that stuff. And then, of course, the last one, your surgical airway. All right, so pay your taxes. BVM, simple thing, anybody can do it. EMRs are trained and above. Use your adjuncts, your OPs, NPs, all that stuff. EC maneuver there. A little bit of the head tilt from the aspect if you need to. Of course, if it's in a C collar, can't do that. Ideally, how many people for this? 2. All right. It's the essential things. Keep the dentures in. Water soluble lubricants for good seals, especially with a lot of facial hair and all that. The combi tube, blind insertion, just like most of these aspects, all the adjuncts, the salts, the combi tube, the LMA, your king, and all that stuff. Inflate the balloon. Of course, it has, depending on which one that you, which tube, because it'll have two balloons that you have to blow up. From there. Seals, ideally the oropharyngeal, the nasopharyngeal, and then of course ventilate through the blue port. Good breath sounds, no air, continue ventilating. No breath sounds, stop, ventilate through the white port. If you've never seen it before, has anyone actually seen and played with the combi tubes before? Yeah, a long time ago. These are dinosaurs. But I have seen they've actually reinvented it, and it's slowly coming back. So LMAs, ideal original intent of the LMA was in the operating room for simple procedures. It is not FDA approved for what we do, just like actually the King LT. It's not FDA approved for pre-hospital settings, even though it's used. Routine emergency procedure and all that stuff, if we don't know that there's going to be a difficult airway, for the patient that is profoundly unconscious, that we don't want to put something in the back of the throat and then they start gagging and throw up. That would be bad. And then from there, anything with a reflux. In a like patient, basically they go through if the patient has not fasted, if they have any gastric contracts, lung compliance, and then if they resist the LMA, is all your contraindications. Again, for us, the pre-hospital, we don't care. If they're unconscious, unresponsive, they get it. All right. Scope of practice for an EMT is what? When can they use this? When can you use it? Pulseless anatomic, correct. All right. So any of your blind insertion devices, it must be pulseless anatomic. Just an aspect of what it looks like. If you've never, a lot of times this is one of the surgical ones, or they play with this one, the intubation LMAs. What a lot of times they'll do is take the cuff down here, pull a little of the air out, and it makes it more rigid. And then on the back side, you can put your finger in the little cuffed area between the cuff and the tube, and it slides right in. And then you just pump the air back in, and it sits inside, or it seats itself in front of the glottis and epiglottis and all that stuff. So right there, as you put your finger in, and kind of sort of goes through. Usages, again, slip it through, 1, 2, pull the air out, set it, put your air in, pull it out a little bit, and then make sure that it's working. And that's where it's sitting and all that stuff. The difference between the intubating LMA and the LMA is it has a little handle, so when you sit it in, you can pull it back. And ideally, this little plastic piece here will come off so that you can shove your ET tube down, and then you just pull the top part of the ET tube off, and they have most of the time it's there. There's a little device that you, once you sit it through, you put the device inside and you shove down on the ET tube as you pull the LMA out, and it allows, or it keeps the ET tube inside. Works about half the time from when I played with it. Test with the LMA's biggest thing is make sure the cuff works. Lubricate sometimes, insert for the comatose patients, and then you can reuse it if you want to. King LTS is going to be by far our gold standard for the majority of us. From the ass, has a single tube with a single port, unlike the combi tube. Both of the airway ports are inflate with the single airway and all that stuff. And then depending on the depth mark, so you have the depth mark. Most of the time you just pull it down or you put it all the way in until you hit the teeth there. And then once you get put the air in, it'll pull back up, or you can pull it back out a little bit for it to seat properly. Which is just like everything else with the LMA. The whole aspect they don't have a gag, for the EMPs, pulseless apneic. For the advanced EMPs, they just need to be apneic, and of course, medics have fun. Different sizes. I assume you guys are carrying everything here. For the most part, you can go down, on a 2 to about 1 year of age, which is, 1.5, which is about 10 kilograms, 10 to 12 kilograms. So anything under that, of course, it's hard to use the King. I mean, even most of the literature out there that's, for the pre-hospital setting, they're not even really saying intubating and all that stuff. Just ventilate with a BVM and then transporting the kids and all that stuff. King Vision, what you guys have here. Anyone seen the Storch CMAC before? So this is about $3,500, $4,000. Of course, the King is about $1,000. The good thing with the Storch though is it's reusable. Versus the King, you have to the bottom part gets thrown away. If the video goes out on it, you can it's the only one that it's, from their aspect of how they pride themselves, it's the only one that you can actually revert back to doing manual laryngoscopy. All right. So that's why they market it the way is there. And then there's some departments out there that are using glide scopes that have a lot of money and all that stuff. Advantage, of course, is Airway. You can visualize it is don't need a lot of neck mobility. You don't have to crank up on the person's neck just to slide in. They must have, for the most part, a larger mouth, because you have to put they don't have a pediatric on that. But for the glide scopes and all that stuff, there's a pediatric. Problems though, of course, stuff, vomit, fogs everything. Or the ice, like to still refer to it as. They have a newer bougie out there that I like, that you can actually coil up, and it's more flexible, and all that stuff. So really, you can crank down and make a nice hockey stick if you know that they're going to be a real anterior person. So going from the aspect, you should always know where your bougie is. Too many times it can save your butt. If you can't, from the aspect you can't get the tube there, you can put a bougie, throw the tube over top of that. Surgical crike, use the bougie, so I'll make the nick in the skin with the knife and all that stuff. And the first thing that I drop in there is the bougie. I don't care from there if you're driving down the road and you bounce and you just had your finger in there and you get thrown over. You lost the airway, you lost the hole. So if you put a bougie in there, it's there. Advantages, of course, gives you definitive airways, easy to learn, inexpensive. Anyone can do it blindly. Does have a little bit of practice, and of course, it's not recommended. I disagree, sometimes with that. Transtracheal jets, or your needle crike, however you want to call it. So from the aspect, you find your thyroid crical cartilage. You have usually a 16 gauge, 14 gauge Gelco, ideally. Attach a syringe on it. Ideally, if you have a little bit of water into the syringe. And then as you're penetrating into the membrane, pointing towards the people's feet, aspirating a little bit as you enter. Once you get in and you get a whole bunch of bubbles, stop. All right, what do you do after that? Take the syringe off, attach the adapter. What size adapter works on it? Yeah, yeah. The one that's yeah. So if you take an ET tube, usually you're a size 3, size 4. I've even seen them up sometimes up to a 6. Doesn't always, but the smaller ones you can actually attach onto the tip of the gel coal, and it'll fit. Then you can attach your BVM and all that stuff to it. All right. The problem with this is not so much of oxygenation. All right? The problem is, unfortunately, it's the wrong terminology. It's not ventilation. All right? You can oxygenate, but you can't really ventilate that well. So you're not getting rid of the carbon dioxide, but you're just giving them the oxygen. Surgical, and then of course, that's the surgical airway of choice for kids under 8, ideally definitely under 2. Effective temporary airway, you get 30 minutes, okay? Kids can tolerate this for about 30 minutes. Disadvantages, of course, you need the equipment, high pressure oxygen, and then you don't, protect against aspirations and all that stuff. And just to reiterate, you're not able to really do ventilation. You're not transmitting that air back and forth. You're not getting rid of the carbon dioxide. Retrogrades? Anyone practice with this one yet? Okay, I'm the pig and all that stuff. All right. So the retrograde intubation, the first step of it is very similar to doing your transjet. So using the needle. So in this time, instead of pointing towards the person's feet, what you do is you point towards their mouth. Same procedure, everything else. 16 gauge Gelco. I have attached a little bit of water. Push into the membrane, aspirating, get the air stop, pull the syringe off. And what you do is they make a wire. It's out of our, whenever we do our central lines, but you can get the wire by itself. You just pass the wire through, goes up, grab your McGills inside the mouth and pull the whole wire through, and then put it through the eye, shove the tube down. And as the tube goes inside, it hits where the wire's coming through the trachea, and then pull everything out, and you know where exactly it is. So no, this is a kind of sort of another form of blind insertions and all that stuff. Partial coccygeal hemorrhage, thread the wire, exit through the mouth, got to trachea back in, and then of course through the vocal cord and all that stuff. This is a form of definitive, minimal neck movements and all that stuff, but it takes time, okay? If you don't practice this a lot or that aspect, it does take a little bit longer to do this. Requires skills, not recommended if you can't intubate and ventilate. All right. Digital intubations, all that stuff. Some girls, unfortunately, apologize, or smaller men need longer fingers and all that stuff. The digital intubation I did a week and a half ago, she had the female had a small mouth, but it was just, I could barely get my hand in there to get everything through. Really unconscious, not used, life savings. Poor lightings, disruptive airways, whole bunch of blood in there, equipment failure, intubation failure. This is your last ditch effort. And with this, since I'm right-handed, I put the right hand in to the patients if you're the patient's left side. So I'm looking at their feet. Put your hand into the mouth, and you can actually feel the glottis, epiglottis. Lift up on that, and then take a 6-0 tube, 7-0 tube, whatever, and slide it right between your fingers. And as the tip gets down to the very end, using the middle finger, all you do is just flip the tip up. It's also good if you're using the tube that has for like nasal intubations. Yep, using the endotrols and all that stuff. So you can, one side, you can kind of pull it up and help, takes a little bit of work, but to do both of them at the same time to really get that tip up there so to push it through. And of course the crike. Okay, this is it. Surgical needle. Okay, using a Selger basically or percutaneous. Most of the time we'll be just using a simple knife cut. Throw a bougie or whatever, keep the hole open, throw a 6.0 ET tube in, secure it, and off you go. All right. So that one patient that had his face blown open, trying to, if he's really gasping and all that stuff, trying to intubate him, almost next to impossible. He'd probably be getting a surgical crike. No procedures, it can go fairly quickly and all that stuff. Final, okay. In the guidelines, this is the final pathway, okay, for the difficult airways. If you can't intubate, after 2 attempts, then you go to your any of your blind insertions. After those don't work, then it's, can you ventilate BVM? That doesn't work. Then you're going in, you're using the knife. Sometimes if it looks bad enough, while one person's attempting to intubate, one of the medics think about this, okay? Start prepping the patient and getting ready, okay? There's times that you can actually make the cut through the skin, okay, while they're intubating, and if they can't get it, you just finish the cut and go from there. Burp, backwards, upwards, right pressure. Don't forget about that. Get everything into view. That helps. If you need to, for the medics, grab one of your helpers, your EMTs, put their hand on top of it, and then set your hand on top of theirs, and then do the burp. Once you get the view in place, what do you tell them? Go move. Okay? And then that kind of sort of helps. Recognize, okay, how much time do you need? Who else is around? Know your backup procedures. What equipment do you have? And then know your old methods, new methods, and all that stuff. Well, that went a lot faster than what I thought.